Welcome everyone to the December 17th, 2020 COVID-19 clinical rounds on innovative PPE strategies. My name is Richard Hunt. I'm an emergency physician who serves as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 challenges and successes. If I'm a clinician learning about COVID, the clinicians I want to learn from are those with the most experience. This is a voluntary public-private collaboration, and thank you to the multiple professional organizations who have collaborated on these rounds. They are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience rather than recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on healthcare providers sharing their successes and challenges with other healthcare providers. Thanks to Project ECHO, Dr. Struminger and his team for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. On Monday, December 21st will be EMS rounds. While still a work in progress, the concerns recently expressed around tremendous increase in time for offloading of patients is one that obviously impacts systems in healthcare, and that one may be the focus of those rounds. On December 22nd, we will have critical care rounds focused on pediatric ICU care of adult patients. Those December 22nd rounds will be the last rounds for 2020 so that we can give a break in recognition of the holiday, support of clinicians fighting fatigue, and in support of their mental health. Stay tuned for announcements regarding rounds for 2021. Thanks to NETEC, the National Emerging Special Pathogen Training and Education Center, for their support with these rounds. These rounds and NETEC's webinars complement each other. I'll now turn this over to Dr. Bruce Struminger.
Thank you, Rick, and thanks for everyone for joining today, particularly our colleagues zooming in from Mass General and our expert panelists and all the participants. Just going to go over a few routine logistic items. Here we go. So we actually have there are about 100 people in the audience today, so that's a great number, and we really want you to share your questions and comments, and hopefully we'll be able to get to many of them. Put those in the Q&A feature at the bottom right of the Zoom toolbar. If you have technical or logistic issues, please put those in the chat function, and Rick in a few minutes will be asking a crowdsourcing question related to today's topic about PPE. Please enter your response in the chat so that we will be following those there. We're recording today's session as we do normally, and your attendance is consent to be recorded. Thank you for that. The recording will be up on our website, the HHS ASPR Clinical Rounds Project ECHO website, and we'll share a link to that. It should be there within a few days. Presentations, the presentations for today, hopefully were shared via a link in the announcement that went out this morning, but we'll also be sharing that on our website. For those that would like to get CME and continuing professional development credits, we're offering those through the University of New Mexico, where Project ECHO is based. We'll put a link in the chat about 15 minutes before the end of today's session. And there's a 2 to 3 minute CME survey that's anonymous. We really appreciate your feedback. It's how we continue to improve the clinical rounds program and know what topics you want to hear about next. So please fill out that survey and take advantage of the CME and CPD. Just as a reminder, these learning sessions are focused on improving patient care and health systems and supporting clinicians. Let's keep them apolitical and non-commercial. Thank you for that. And just a few words about data use. You share data with us when you register, when you answer the polls, the polling questions Rick's going to ask during the session, in the Q&A, et cetera. We just want you to know we take data stewardship very seriously, and what data we do share with Rick is all de-identified. Rick mentioned that NETEC, the National Emerging Special Pathogen Training and Education Center, is a partner in these rounds, and that they have their own terrific webinar series. Yesterday, they did a webinar on responding to vaccine hesitancy. That was recorded and is available on their site. Tomorrow, they're doing a webinar on alternative care sites. So we encourage you to sign up for their webinar series and go to their website to find things in the archive that would be useful to you. Also, just want to give a reminder about the HHS ASPR COVID-19 Outpatient Therapeutics mini-series that launched last week. The second session was yesterday, and in January, the first week of January, the first Wednesday at noon will be the next session, and we'll share a link in the chat to register for those. They're primarily now focused on monoclonal antibodies, but will also cover polyclonal antibodies and other outpatient therapeutics. With that, I'm going to hand the mic over to Dr. Rosha McCoy with the Association for American Medical Colleges. Rosha.
Thank you, Bruce. Yes, from the Association of American Medical Colleges, I'm again reminding folks of this resource, the Clinical Guidance Repository, Coronavirus Clinical Guidance Repository. As you know, it's an open access resource for all clinicians. We bring together information from academic medical centers, specialty societies, and federal partners. We've continued to update this. We're going to also create a vaccine subpage here soon, so be on the lookout for that. We're also very proud of our presenters today who are from our member institutions of the Association of American Medical Colleges, and we look forward to that. Thank you so much.
Rick, back to you.
Thanks very much, Bruce. Rosha, thanks very much for making some connections that made these rounds happen. Much appreciated. PPE has been on the minds of clinicians ever since the beginning of this pandemic, and has persisted, and it's not going away. So one thing that would help is knowing where we are today by answering in the crowdsource, in the chat, the response to the crowdsource question. Today, what is your organization's most pressing challenge with PPE? So it's today. We're not talking about 5 months ago, but right now, what's your organization's most pressing challenge with PPE? It'd be great if we could see some responses to that. If we could, each of the panelists could please take themselves off mute. I'll ask each of you to introduce yourselves briefly before I introduce our speakers. Dr. Schneider, great to see you from ASAP, please.
Hi, Sandy Schneider, Associate Executive Director for Clinical Affairs from ASAP, and prior to COVID was a practicing doc in Fort Worth, and can't wait to get vaccinated and get back on the line.
Thanks, Sandy. Great to have you back. Harry?
Hi, I'm Harry Seibold. I'm an EM and EMS physician from Helena, Montana, past state EMS medical director, and I'm on a COVID assignment in Odessa, Texas right now.
And I understand, Harry, you might have to drop to go take care of a patient in the ICU. Always like that's the priority, and go when you need to. Dan Gerard, please.
Dan Gerard. I am the president-elect for the International Association of EMS Chiefs, and I am also the EMS coordinator for the City of Alameda Fire Department.
Thanks. Dan, good to see you again. Carol?
Good morning. I'm Carol Cunningham. I am the State Medical Director for the Ohio Department of Public Safety Division EMS and an emergency physician.
Thanks, Carol. Dr. Thompson, great to have you back.
Thank you, Rick. I'm Dave Thompson. I'm a clinical professor of emergency medicine at East Carolina University and the medical director for Vidant East Care.
Thank you. Thanks all the panelists for returning and joining us at noon once again. So It's an honor and privilege to introduce our speakers today. Dr. Ali Raja is the co-founder of Get Us PPE and executive vice chair of the Department of Emergency Medicine at Massachusetts General Hospital. And along with him, Dr. Shuhan He, he's the co-founder and medical lead for Get Us PPE and an emergency physician at Massachusetts General Hospital. Great backgrounds, love the Zoom backgrounds for both of you. And I'm going to turn this over to you.
Fantastic. Thanks, Dr. Hunt. Much appreciated. And thanks for allowing us to be here. Dr. He and I are really excited to present to such a wide and diverse audience. I was trying to look through and Google some people's names from the attendees list, and everybody seems to be from everywhere. Before we start, I just wanted to thank Dr. McCoy for making the connection between the AAMC and this group, simply because of the fact that our organization that we're going to talk about today, Get Us PPE, was founded by a number of emergency physicians from large academic medical centers here at Mass General, down at Brown, out at OHSU. So thanks for making that connection, Dr. McCoy. And Dr. Schneider, all of us happen to be emergency physicians and members of ACEP, so it's great to see you here as well. That's fantastic. And by the way, having so many emergency physicians in the room, I think Dr. Cunningham told me in a text message that it's kind of like herding cats to get us in a room together. So I'm very impressed that everybody's here. As Dr. Hunt mentioned, my name's Ali Raja. I'm an emergency physician at Mass General, as is Dr. He. And I'm going to talk a little bit about our organization, Get Us PPE. I've put some links in the chat for you to look at afterwards, and I will share the screen. We actually founded Get Us PPE, and I'll describe that in just a second. But it's an organization with a singular mission. It's to get personal protective equipment, to get PPE to the frontline workers who need it the most. That's it. And the background is that back in March, a bunch of emergency physicians realized that we were in trouble. We weren't getting PPE to frontline workers, and we honestly didn't even know what the need was. And so over the past 9 months, we've founded the largest national organization for getting PPE to frontline workers. And absolutely, we're a nonprofit in case anybody was interested as well. We started as a posting board, and we're going to use a couple of analogies to companies that we have no relation to, and I apologize for any copyright infringement to Craigslist, but a Craigslist style posting board for PPE donations and requests, basically allowing those folks who had PPE or who needed PPE to post and then connect themselves. Now, over the past 9 to 10 months, we've made the largest non-governmental database of PPE shortages nationwide and have delivered millions of pieces of PPE absolutely free of charge. We're doing this in a new way, and we're leveraging as much technology as we can with the goal of using this as a system to really change the future of disaster relief. How this works is that frontline facilities request PPE on our site. And when you get this PowerPoint, you can click on this link to actually go to the PPE request site, or you can just click on the link in the chat that I posted a few minutes ago. We source PPE donations. Either we source them from makers or who are donating them, or others who are donating them, or we use funds that have been donated to buy maker-made PPE. And then we match that PPE to the facilities that have notified us that they're in need of PPE. And then, just to take this all the way to the end user, we use regional volunteer teams to help with last mile deliveries. You can see in the picture here, volunteer pilots that worked with us to deliver respirators to Native American territories. Our national team has over 150 volunteers. And again, leveraging the technology that we have available, we use Slack to actually coordinate all of this. We haven't met in real life. Aside from the fact that Shuhan and I happen to work at the same hospital, the vast majority of our team is fully virtual, which is just sort of emblematic of the way things have gone, not just in this pandemic, but the way that a lot of nonprofits are working now, period. We have really innovated in multiple areas, and I wanted to point these publications out for 2 reasons. Number one, Dr. He, despite just finishing residency a couple of years ago, is passionate about and a real expert in digital innovation. He has done this for many, many years. And because of that, he's been able to publish a few papers specifically around this work. we first talked about how we deployed these tools, how the system was developed, and published that in the Journal for Medical Internet Research. Then the Lancet published our database, the NEED database. Now, this was back in June. Our most recent data about PPE need is actually in the second of the 2 links I posted, and you can download that PDF looking at what the PPE needs are around the country. And then, and this is the really innovative thing that Dr. He is going to talk about in just a couple of slides, we developed a novel algorithm for matching PPE needs to folks who had PPE. And this was published in Nature. Dr. He, you want to take it over from here, please?
Absolutely. Thank you, Ali. And I think the really salient thing for everyone in the audience is understanding the scale of the problem, right? Despite the media attention, especially in the early days, the PPE shortage has persistently been a problem throughout the entire pandemic. It has never really abated. And to really highlight exactly how bad it's gotten, especially in the recent months, our PPE shortage index we put out every month to understand the number of requests we get and understanding the scale of the shortage. So the first thing is that since March, we've received over 19,000 individual requests for PPE, close to 20,000 requests. That's from individuals. And for every one of those requests, there's a significant amount of PPE that's requested. Now, in the last month, in December so far, we've had a 240% increase in the number of requests, and that tracks very, very closely to the amount of COVID in each state. So it tracks very closely to statewide COVID case rates, but certainly nationwide has increased as well. Now, what's really salient here is that when we see patients in the ER, we often see them from nursing homes where it spreads like wildfire. And that is something that is consistent, has been that those smaller facilities are the places that most in need of PPE. 90% of requests have come from things like places like hospitals, nursing homes, group homes, even COVID testing sites where they don't have PPE, but they certainly have a high exposure to PPE. When we go to when those patients ultimately come to the hospital, we then use more PPE, certainly further exacerbating the problem. In addition to that, this is a nationwide problem in all of the states. And so requests from frontline facilities in all 44 states, 44 states and DC. Some of these states are a bit underrepresented in our database, and it's something we're aware of. So we are working to do more active outreach as well in those states. Now, let's go to the next slide. This is something that we are learning very quickly on the ground of how to execute and how to do this in a way that helps everyone on the ground. So we have, as you saw in the last slide, a lot of PPE need. And so in the supply that we have been able to procure has not been anywhere near that demand, and we haven't been able to fulfill that amount of supply. So what we've needed to do by necessity is to make sure that we are triaging to the places that need it most and in the most efficient way possible, and not simply to the places that are closest to where the supply came from. Most of the supply is from small donors or makers of 3D printers. So what we have done is to create a matching algorithm, and what we call this like an Uber for matching. Again, not linked to Uber in any way, but certainly a way to understand how we function to basically match the supply and then the demand, and automatically say, we're going to ship this to you because you're the one that needs it most. So let's go to the next slide. And to understand how much better this works, when we first started, we were having volunteers match the supply. And so this tracked very well to the number of hours that we could put in. And it just wasn't possible to match all of that. As we had more people match supply, it basically increased logarithmically or linearly to the exact number of hours we were able to put in. But the second we implemented this algorithm, we were able to increase our matches per day to about 279% increase. And our matches increased in efficiency. It's pretty significantly to 46% of the matches were under 30 miles. And this may not be necessarily a good thing in the sense of we were able to match all of our supply to demand. Demand far outstripped supply at every single point, and we've never been able to give all the PPE to all the requesters. However, we were able to distribute it all very, very quickly using this algorithm. Okay, let's go to the next slide. So what I want to emphasize is that this shortage has been persistent throughout, but we can learn a few things that will hopefully be relevant for the next pandemic, for the next emergency logistics issue, and that this is a way that we can approach disaster relief in a whole new way and hopefully not be in the situation ahead of time. The first thing we did was as Dr. Roger mentioned, we created a Craigslist, right? People were posting the supply they had, and then they talked about the demand, and people would drop them off. This really just rewards people who are closest in large metropolitan areas where they tend to have actually a pretty good amount of PPE. What we eventually moved to was this Uber method, as I mentioned, and this efficiency matching. So we would decrease the amount of miles that the PPE would need to travel. This still does not truly recognize the need of a facility. So for example, places with high vulnerability populations, both racial, socioeconomic, is not get taken into account in an Uber method, purely efficiency. Or places that we know are going to be vulnerable for COVID. So what we're doing now is to develop better algorithms to look at our training set, understand, hey, COVID case incidence is really high in New York, for example, and this is a nursing home that probably is going to be quite vulnerable and not have PPE. Let's reach out to them and let's see if they need some PPE and be proactive about this so that it doesn't spread. So we can use that PPE as an intervention before it spreads and not afterwards. And so let's go to the next slide. We see this as a really important part of future crisis response that can certainly help. It won't solve the problem, but it certainly will help. It can be used for a lot of different things. So for example, right now with the vaccine distribution, who needs it most, right? We can do this algorithmic matching. We can also do things like food shortages, or as we see common in the ER, homeless shelters, right? Right now, oftentimes people come in and it's first come, first serve for beds in the homeless shelter. So this can be a way that we match those most in need. It can be used for resource distribution in all kinds of different scenarios, whether it's natural disasters, pandemics, or any sort of crisis where the demand far outstrips supply. And so what we actually are really proposing is a national strategic reallocation system. In the early pandemic, we had a national strategic reserve for PPE, but we can really imagine that when any disaster scenario comes to fruition, we can really have a reallocation system where there is supply and we send it to places that are most in need at that time. So we can imagine this is a future. We're certainly working on that. And certainly there's a lot of bright people in the audience. We would love to work with whoever may have interest in this kind of work and something that we're really interested in developing in the future. So thank you for your time. Any questions?
Yeah, thank you very much. You certainly enlightened me on a dimension that I hadn't heard of, thought of until Rosha connected me to the two of you. So really appreciate the presentation. So one question, then I'm going to turn it over to the panelists for their questions or comments. The prioritization, and I saw the future, I got a ton of questions, but this one in particular. So I saw with the future, okay, so prioritization and proactively try to find and push it out rather than be reactive. But so for now, how are you prioritizing the requests? Like in the real time, like right now, how are you doing that?
Yeah, that's a great question. When we first started, it was purely based on efficiency, right? We need to be as efficient as possible for a limited number of man hours and essentially shipping logistics and optimization. What we've done slowly over the last few months is introduce something called the fairness framework, which would take into account—
Johan, I'll show that slide too while you're talking.
Perfect. That takes into account basically the need. It is difficult to get this right, let me be clear, and something that we have to get right because lives are at stake, right? So as we develop this, we're really going to publish it in a way that can be reviewed by experts. But what we're doing essentially is looking at the facility type, the number of PPE that they have left, taking into account caseload as well. So COVID case rates in the community, the population that the case mix of that facility as well. And then what our algorithm does essentially is make it look like they're a little bit closer. So it prioritizes them based on that same efficiency method, but make sure that we are able to allocate it in a more efficient way. So this is something that we're going to work on, and we want to make sure that's publicly known. We are working on that right now. It's not quite.
And I think that part, as Dr. He mentioned, is key. That this is something that we as experts have thought up, and we've really put a lot of thought into this. But we can't have taken into account every potential fairness and equity point that needs to be built into this framework. So as Dr. He mentioned, if you've got ideas, this is why we're presenting to you, is we would love your thoughts and ideas, and you can reach us through the webpage. But this is obviously our thoughts. We've put a lot of thought and time into this, but we'd love your input as well.
Yeah, you certainly, I mean, like, put your finger on, like, okay, it's a scarce resource. I mean, I saw that in the slides, you mentioned it, and indeed, this is like allocation of scarce resources, and you're part of the solution. And I think about crisis standards of care immediately as I think about what you're doing. It sounds like you've factored in a lot of it already. So anyway, just applaud the effort and appreciate it. So turn it over to the panel. Raise your hands if you would, so I can figure out who's first and second, et cetera, et cetera. Rosha, yeah.
Yeah, one smaller question, a bigger one. Well, it's not smaller, but I'm just wondering, do you guys store this stuff somewhere? Do you have a room to, I would just thinking back as a CMO, where do you put this stuff in a hospital? I don't know if you have more of an issue even for you.
Yeah, that's a good question. We actually drop ship as much as possible. The need for warehousing is something we've looked at extensively, depending on the type of PPE, right? But what's really nice is that a lot of PPE is made by open source makers and additive manufacturing. And so it's made on demand and then shipped on demand. It skips that step entirely, making the process a bit more efficient.
I guess I have one other question is, as I think ahead, one of the projects we may start working on is a vaccine acceptance and confidence project. And I wonder if there's a way, and we may connect back with you to talk soon about whether there's a way to use some of your outreach, particularly to vulnerable communities, to get messages and get feedback from those communities about what their needs might be around vaccine acceptance.
Absolutely. Would love to partner with you on that. That's such an important point, especially with the most vulnerable of our patients.
Great.
Yeah, and while you're at it, if you could do the staffing shortage thing too, that'd be helpful.
I've got 20,000 nurses in the other room, so we'll set them right out. Yep.
My guess is, and already looking at the chat, obviously people are wowed by your efforts, and I think it just like boggles the mind to think about the potential. And to me, the piece that's on the front end with this, you've already like thought through, okay, it might not be perfect, but you've thought through a theme that clinicians, and I'm so proud of my fellow clinicians for, I'm not on the front line right now, I'm listening to you, but the equity issue that everybody sees and highlights in an extraordinary way on these rounds. You got that concept in there. And the other part is what's always been clear is the government, given where the government has been in the past, is not ever going to be able to take care of catastrophic events alone. And so you're forging a way for the private-public collaboration, which these rounds are, in some new ways. And to me, what'll be fascinating to see is, and I'm hopeful, and I'm editorializing, that this is not like a one-time occurrence because it was a catastrophe pandemic and then it all disappeared, but the way to take this and make it work in the future. So I'm going to stop talking. Carol and then Dave Thompson.
Yeah, I was curious if you accepted requests or received requests from other healthcare providers like EMS agencies, nursing homes, et cetera, that were running out of PPE.
Yeah, we accept from all type of facilities, and one of the things we ask for in terms of that fairness framework is the type of facility. So we have other categories as well. It is something we are actually working on to just remove forms. This is something that is a long-term thing, but in theory, in any sort of disaster relief, you're not gonna be able to create a form depending on what people need, right? But if you have enough data, what you can start to do is start to use the technology to learn about people's needs on the ground without asking them specifically what they need. So you can imagine shortages via, social media, free text, so we can understand, people's needs and also facility types and about them and demographics. Something that is certainly on a roadmap to develop as well. But we certainly look at all types of facilities and their information.
And that included
Dr. Cunningham. Sorry, go ahead.
Did that include EMS agencies?
Yeah,
it did,
absolutely.
yes. And actually, you can go to our website and see more of a breakdown in terms of the number of facilities and the types of facilities that are asking for PPE. And as Dr. He mentioned, it really is the vast majority are not large hospitals. You know, we all, the folks who built up Get Us PPE as the initial founders were all from large academic medical centers. But the folks who now are asking for PPE are typically either smaller hospitals or non-hospital facilities. Think everybody from homeless shelters to even vaccine clinics to primary care clinics.
Thank you.
Say Dave, and then I think I had Dan Gerard, I think, next. Yeah. And I got Sandy. Sandy, I got you. Okay. All right. So Dave, Dan, and Sandy. Dave.
You mentioned the disaster response. That's a very dynamic situation, at least in my area where we have hurricanes that come through. How quickly can you implement this, your algorithms, and get the right stuff? Because so often people who need diapers get water and people who need water get diapers.
Yeah, it's a good question. When we launched our site, we were able to do it within probably an hour or two, using kind of the newer technology that allows you to do generic frameworks, stuff that you don't have to build. Like, you know, the way I was thinking about is healthcare.gov and how big of a disaster rollout that was, right? The technology that exists now, you can do things in an hour max. So we can deploy those digital tools, and that's certainly one part of our strategy to replicate in the future. But as you mentioned, it's going to be really dynamic, right? It may be that it's something for food, or, you know, in this pandemic, ventilators, and we weren't aware of that, right? So it will be a learning curve, but as we learn and as we grow and as we implement, we will probably get more and more efficient with time.
Thanks. Dan Gerard, and then Sandy Steger. Dan.
First of all, Docs, great presentation. Thank you very much. You know, back in July, the White House, you know, the conference call we had with the White House, and then the DHS PPE task force, you know, they told us, they said supply chains wouldn't be restored until the spring. It's kind of like a sobering moment when we heard that come out of the vice president's mouth. And, you know, the goofy thing is that you guys are doing great job with just in time supply and manufacture, but, you know, we really haven't addressed the issues related to sustainable and reliable restoration of the supply chain and restoration of PPE. It's really a conundrum, because when you think about it, the nursing home patient is going to be handled by the nursing home. It's going to be handled by EMS to get them to the hospital, and then it's going to be managed in the hospital. And so, you know, we're competing for the same resources to take care of the same patient. And so how are you guys looking at measures, you know, collaborative measures incorporated into systems of care that emphasizes safe harbors for purchasing, allows for purchasing of PPE across the continuum of care, you know, sort of get these models together, you know, because we are going to need, you know, we're going to need supply depots. We're going to need places where this stuff is stored. And, you know, we're going to have to really look at PPE, not only what works, you know, in the long-term care facility, but what works for EMS, what works for the hospital, what makes sense, you know, and how do we do that? How do we all come together and leverage that power? All these little agencies functioning as one. Are you guys looking at that?
I'll tell you, Mr. Gerard, the fact is that back when we started this back in March, I remember these conversations. We thought that Get Us PPE would last for a month or two, because we expected a centralized government response that would do exactly what you're saying would be done. Now, again, we're keeping this completely apolitical, but all I can say is that that hasn't happened. And so we were a little bit surprised this summer, and come July, we said, wow, I guess we still need to keep doing this. And now it's December, and we clearly still need to keep doing this well into the next year. What we have focused on is really, as I mentioned earlier, our mission is primarily about just getting PPE to the frontline workers. Most of what you're describing really needs a broader national effort that's a little bit outside of what we have done so far. Honestly, could we do it? Could we help do it? Yes, but we're a volunteer organization, right? The kinds of things that you're describing really need a centralized governmental response. Dr. He, I don't know if you have different thoughts on that.
Yeah, so, you know, I think the discussion of just in time versus just in case is really salient here. There's a lot of discussion about, the need for initial strategic reserve to make sure it was filled. One thing that Dr. Roger mentioned was that we always thought there would be a white horse that came in and solved the problem, right? But there never was. And you actually look at the numbers, it was never going to happen. The National Strategic Reserve for N95s needed 3 billion masks to truly satisfy demand. And at best, when it was full, it was almost a tenth, maybe a fifth of that. So it was always going to be a patchwork, right? It was always going to be makers making, regular cloth masks and then, recycling N95s and every single strategy on the table, because in a disaster scenario, that's what it requires. One centralized, one solution is highly likely to failure, and you need that redundancy, right? Because that's robust. And so organizations like ours present one strategy to help, but certainly every strategy was on the table, and that's going to always be necessary, I think, in any disaster scenario that we can help to solve the problem. But certainly in a pandemic like this, where it was such a high need, were we truly going to be able to fully solve the problem? I don't really know, because it really stresses the system, right? So my answer to that is, I think all of the solutions need to be on the table, and hopefully we're better prepared next time. But are we going to be truly 100% prepared? I don't totally know.
Yeah, it begs the question of okay, to what level of preparedness do you actually aspire to? And that's a much larger question that we're going to solve right here. Sandy.
Yeah, so first, guys, thanks a whole lot, not only for your presentation today, but for what you did. Early on, I think ASAP thought about getting into this space, and we saw what you guys were doing, and we stepped back and said, go for it, because you were so far further ahead and had the skills actually that we didn't have to do this work. And so I thank you for doing it, because we really needed that. You guys and to whatever extent you work with Project N95 have been a lifesaver for our docs, and we thank you for that. I have a question though. I know you're volunteers, and I know you can't wait to get back to your day jobs and your real jobs back there, but you've created such an interesting program and interesting technology. Where could this be applied? Because I think someday the pandemic will be over, maybe. But I think it will be over. And so where can this be applied? Could this be applied to bed shortages? Could this be applied to other types of shortages? What in your dreams before you go to bed, what do you think about? Each one of you get one of where this could be applied.
Sean, why don't you go first?
Homeless shelters. That's the one I think about. It just makes no sense the way we do it now. I mean, there's this dramatic shortage, and we have such a problem. And I think in any urban metropolitan area, right, there is that issue where it's essentially first come, first serve in a lot of homeless shelters, and supply far outstrips demand. It's not a disaster scenario, right, in theory, but it is, because it's disaster all the time. We always need to make it better. We need to make sure people have beds and shelter and safety. And that is the one I think could really be solved with technology like this, to make it really, really efficient and maximize all the beds in a way that gets to the people who need it most.
Cool.
Given the fact that it snowed 1.5 feet here yesterday and it's 20 degrees outside, we've been thinking about that a lot over the past few days, is making sure that our undomiciled patients have places to go tonight. So that was going to be mine as well. But I'll say the other way to do this is food insecurity. There's a lot of food deserts out there, and having people sign up for Meals on Wheels, don't get me wrong, great organization, but that isn't the kind of solution that we need that's going to distribute food to people who are truly having food insecurity. We've all heard about the issues with the dearth of access to school lunches, and so many people are remote. That kind of thing right now, kids shouldn't be going hungry simply because of the fact that they're not able to go to school because their school has gotten to be remote. There are solutions out there. We can apply the same kind of framework to other solutions, Sandy. So thank you for bringing that up. We'd need a new name, but there's definitely ways to apply this.
Get us food, help, shelter. I was going to suggest mental health resources as a third one to put on your list.
Great point.
And there are some work going on that I'm going to be doing this afternoon on a new dial number 988 around that. Anyhow, thank you guys again. You've been really amazing.
Thank you.
Thanks for all the comments and great dialogue here. Dr. Strominger has a question, comment, and then we'll do some polling.
Thanks, Rick. And thanks, Ali and Shuhan. I wanted to follow up with Sandy's question to ask, have colleagues in the global health setting reached out to you, and or have you reached out to try and replicate the model in countries outside the US?
Yeah, early on, we did do technological support for other countries. Certainly a really, really big need, but we pulled back a little bit in terms of the logistics of it, just because it was so complicated, right? You can imagine there's no zip codes in a lot of other countries. It's a completely different system that requires information in a way that we didn't totally understand. We really wanted to focus on domestically. So we do work with a few countries just to help with their web portals, but we don't quite do the logistical implementation yet. Something certainly we want to do in the future. All of these ideas, people in the audience, I'm sure there's so many applications we haven't even thought about yet. So all of the above when we can.
Great, thank you.
As Echo gets ready to put up the polling up, as I've listened to this, it's like so many companies I could see like want to gobble this up and like make a name out of it. Don't ever lose the clinician driving force behind this. That's the piece. I mean, because the value of what you're doing is you're seeing the need and you have a greater feel for what that need is than anybody else. And letting somebody take it over without that driving force behind it, I think would just like be a disaster on top of a catastrophe. So anyway. Not that you were asking, but that's my, yeah. Okay, so let's go to the polls. They're all, guess what? They're all PPE related. Okay, so over the past 7 days, my access to PPE while caring for patients is, and by the way, yesterday on Tuesday when we did the 100th rounds, we had like a record percentage of responses. We went over 70. I can't remember what it was exactly, but over 70% responded. So, let's see what we do here. Also, we don't identify individual responses, but they're aggregated. And for those of you who were on Tuesday, you learned how actually what we share has been used. So. All right, let's stop in a couple seconds here. Yeah, there you go. All right, so by far the same 56% was the most common response. All right, next. The PPE I last used was adequate, inadequate, and not applicable. And when I did this one, when I put this one together, I recall from the early days of the pandemic when I put up a PPE question, and then I got like this, like venomous is too strong, but a chat response of it's not just the PPE, but the adequate PPE. And so therefore, ever since, made sure we get the adequate part in there. Got another 5 seconds and 53% have voted so far. All right, let's stop there. Adequate 63%, inadequate 9%, and then a number of not applicable. All right, next. I think there's 8 in total, so we're about a third through. Which of the following PPE supplies are you most short of today? Select only one response. And those of you who've been participating on rounds before, this is probably the, I don't know, maybe the 20th time we've asked this one. But it is actually absolutely informed us at HHS, the Healthcare Resilience Work Group, on where things were. Early on, it was always N95s, and then it ended up being gowns for a while. as the most frequent, and then it went back up to N95s again. Ollie, and is that sort of what you've been seeing too? Just curious.
It is, actually, interestingly enough, you don't have it listed here, but hand sanitizer has been in our top 3 for a couple of months. But
Okay.
other than that, gloves and masks. Yep.
All right. I'll throw that one in there for future ones. Thanks. All right, let's stop there. N95s. Yeah. And by the way, that one that said any kind of mask, you might want to put in the chat to the Get Us PPE people. Sounds like you need some help right now. Please. All right. Thank you. Next. Our organization has accessed PPE from, and I apologize, I should have put in Get Us PPE. I obviously missed that one. Yeah, this is you can have multiple responses to this one. So. All right, another 5 seconds. We have 50% have voted, all 49%. Great responses, everyone. Like getting 50%, almost 50% all across the board for each of these is really helpful. All right, let's stop there. It's really diverse. I mean, really diverse. Wow. Let's leave that there for a few seconds for people to look. All right, next. Healthcare providers in our organization have encountered counterfeit PPE. And so when Echo sends me the polling results and the participant numbers later on this afternoon, and they're extraordinary at doing it really, I mean, it happens really fast. I then forward these on to the Healthcare Resilience Work Group leadership. And for this one, obviously, I'll direct it toward the PPE people. Carol saying like a song, it's the PPE people. Wow. I know a reach. Yeah, I'm going to wait about 5 more seconds on this one. We got 51% have voted. This one's, I think, a really important one to hear from people on. So another 5 seconds or so. And then after, I think there might be one more, something like that. And then we'll go to each of the panelists for final comment, and then to our speakers for any final comment before we close. All right, let's show the results for this. 54% have voted. 26% said yes. Wow. Wow. All right, next. Oh yeah, there's a couple on extended use policies and extended use of PPE here. A couple of those. Yeah, there's this one and a couple more. Then we'll be done with the polling. All right, 5 more seconds. All right, thank you. 65% said yes. That's, Bruce, my recollection when we've done these before, and it's been months since we did one like this on innovation, these kinds of questions, but my recollection is this is higher. The 65% is much higher than we saw early on, much higher. All right, next. This is about conducting in-house N95 decontamination. And then there's one more after this. All right, let's stop there. 55% voted. Wonderful. 26% indicated yes, 39% indicated no, and then 27% not applicable. All right, and then there's one last one. If you're doing the N95 decontamination, which method are you using? All right, let's stop there. UV irradiation 18% and VHP 14%. Well, thank you all for participating. It's interesting to see. We've done rounds focused on PPE before, but it's been a while since we did deep dives like this, so appreciate that. All right, so let's go around to our panelists. Dan Gerard, anything before we close out from you?
No, again, great presentation. I think that we really need to look at more collaborative models, especially when we start talking about logistics, medications, PPE, etc. Again, great job by everyone. Thank you very much.
Thanks, Dan. Sandy.
Yeah, again, thanks, guys. I think what we've learned, not just from these guys, but from a lot of other things, is just the incredible way that emergency physicians have responded to this pandemic. Most people think about it as the person that's, walking in full PPE to take care of one patient. But you guys show us, and there's been a number of these, and I hope this won't get lost. We're an incredible group, and thank you for being part of it.
Indeed. Thanks, Sandy. Rosha.
Yeah, excellent presentation. I'm just amazed by the work you've done and very proud. Thank you.
Yeah, Carol.
First of all, PPE is saving lives. We need it. And I love your presentation because it's global. Anybody and everybody's welcome to come in. Having said that, at the beginning of the pandemic, everybody was screaming for PPE, but now that we're into it, I'm unfortunately seeing some organizations who used to recycle say, well, my supply chain is fine, so we're not going to recycle anymore. Waste not, want not. I think we also need to have an accountability that makes sure that if you're receiving PPE, that you're doing everything you can to make sure you recycle it and save it, because one mask you throw out is a mask that could have saved another life. So as our society is so elements of our society are into the me, I'm so excited to see that you guys are into the we. And, you know, Rick would be disappointed if I didn't mention any music, but it's just like Gladys Knight. You know, we all got to get on the friendship train, shake a hand, make a friend. And I think in the field of emergency medicine, we're leaders of a friendship train. Thank you.
Hey, Carol, I just got to comment on your waste not, want not thing. And you know, now it's different. Now we're just like going to go back to normal. We're not normal. This is like the worst of the worst, and it's likely going to get worse. And so it's just this fascinating, you know, we've had these like peaks and valleys, and now, you know, we're not just beyond, we're at a peak, but the peak's continuing to rise. And the fatigue factor, the sort of like, well, you know, we'll go back to no. And I recall, you know, Bruce, you probably recall Jeff Dichter, the intensivist that talked on crisis care last week, was really kind of doubled down on now is not the time to like let down. This is the time to like kind of like reach deep down and go on afterburners. And somehow I think maybe it's the fatigue that's just gotten us to where it's just really hard at this juncture.
Well, Rick, I'll email you offline. There's some pretty large healthcare systems that are not recycling now. They were, and now they're not, which I find appalling and actually quite unethical, in my opinion.
I hear you, and thank you. Thank you for bringing it to our attention. Dave Thompson?
Yeah, you know, folks have talked about all the silver lining of this pandemic. Things like these rounds and stuff are one example, but I think your organization and what you've shown long after this pandemic, the ability to match, like you mentioned, food deserts and health inequities, I think that's going to be a legacy that lasts long beyond this pandemic. So thank you very much for doing this and for showing us how you've done it.
Thanks, Dave. Bruce, anything before I turn over to our speakers for last word?
Just echoing all the comments, really inspiring, and keep going.
Yeah. Okay, so Shuhan and Ollie, Shuhan, I'll go with you first, then Ollie.
Sure.
Last
I just want to emphasize how proud I am to be an emergency physician. It's just incredible. The number of people have stepped up. And what I will say is that there's probably people in this audience that you're going to be part of our team, right? There's expertise that we don't know about, how we can apply all this technology and the learning that we've had over the last few months. So certainly we're a very collaborative group. If something you feel like there's an application, please be in touch, and we would love to work with you.
Absolutely. And you know, we know about the great work that Project ECHO does, and obviously that ASPR and the AAMC and ACEP do, but we weren't quite sure what would happen when we came and presented, because we're doing something that's a little bit different, where we grabbed this bull by the horns early on, and we weren't sure how well what we were doing would be accepted, because we're really, we're doing something that we invented. And it's just been amazing to see, as Dr. Cunningham mentioned, that this concept of all of us pulling together and focusing on the we has been accepted by so many people. The fact that you've given us so many great ideas, just like Dr. Thompson just mentioned a couple of minutes ago about how we can potentially expand this, we're going to need all the help that we can get. So as Dr. He mentioned, if you're interested in working with us, or if you want to start your own program that uses some of the things that we've learned, we'd love to partner with you and help. Just let us know. We go to our website, reach out to us. We are a volunteer organization. We don't make money off of this, and we want to work with you.
So Ollie, just so you know, yeah, we made this up too on ECHO, and we're experimenting and learning as we go too. So don't feel alone with that one. But this is, I mean, to me, with Roche's reach out and then connecting to you was, it's been something that I actually been looking for, like, okay, the public-private collaboration, while we have a number of organizations that have shared their logos and they send, the announcements to members, having, for example, Roche from AAMC actually be on the rounds and contribute, and same with ACEP, but then having you know, those that have developed novel, like innovative and really life-saving strategies like your own, you know, in the middle of this, to me has been one of the most gratifying rounds since we started. So really appreciate your contributions. And clearly you've saved a lot of lives that hard to track, but indeed, I'm sure you really have, and deeply appreciate your contribution. So with that, thanks to our participants, great participation in the chat, QA, and certainly in the polling as always. And to our panelists, thank you so much. And to Shuhan and Ali, yeah, keep doing what you're doing. You keep it on, and you have to transcend beyond the pandemic, okay? I mean, you just can't like just drop it, okay? Yeah, morph it. All right, take care. Bye. See you on the next one.
Thanks,
Next
everyone.
Monday EMS rounds. Bye.
Take care, everyone.